So my name is Louise Hanna. I'm a consultant clinical oncologist in Cardiff in the Velindre Cancer Centre. And I'm also the medical director for education and training for clinical oncology in the Royal College of Radiologists. So I'm really delighted to welcome you all, and we hope that in the next hour we're going to be whetting your appetite and explaining to you what a brilliant career oncology is. We all think it's the best career in the world, and we hope that that we'll be able to convince you of it as well. We've got a great lineup of speakers. So we've got, first of all, we're going to go with Dr. David Johnson, who's the Oncology Registrars Forum co-chair, who's going to talk to you about clinical oncology as a training programme. We're then going to be joined by Dr. Ruth Conroy, who is our national recruitment lead, who's going to talk to you about the recruitment process. And then we've got another resident doctor, Dr. Martin Lear, who is going to talk about an applicant's view about the application process. We're then going to have a Q&A session, and we're delighted that we're going to be joined by Dr. Satinder Jagdev and Dr. Simon Pacey, who are two of our medical oncology colleagues, and resident Dr. Ben Pickwell-Smith, who will be able to answer any questions related to medical oncology that might occur in the chat. So we would ask you to use the Q&A tab, and also just to remind the speakers to keep an eye on those so that we can reply to the questions as we go through the session, or not at the or otherwise at the end. I've just shared a picture there of our annual trainee oncology meeting, ATOM. Still, I know trainees are called resident doctors now, but the ATOM is quite a good acronym. So it's still called that at the moment. And that was held in May 2025. And that is a group of our resident doctors who attended a fantastic meeting at the Christie Hospital in Manchester just about a month ago. So we really hope that you'll consider joining us and joining them in oncology and training in oncology. And then without further ado, I think we'll be moving on to Dr. David Johnson, who's an ST7 clinical oncology co-chair of the RCR's Oncology Registrars Forum. So you're going to talk about clinical oncology as a training programme. So over to you. Thank you, David.
Thanks so much, Louise. Thank you, and hello, everyone. That's super. So my name is Dr. David Johnson. As Louise said, I'm a resident doctor. I'm an ST7 clinical oncology. So I really just want to talk through a wee bit about what clinical oncology is like as a training program. So next slide, please, Jackie. Thank you. So I thought really I should start off about why is it I got into oncology personally. I think it's always helpful to hear on others' sort of journeys and why they are where they are. So for me, it really started with a really great placement at university. Why it was great and why I thought oncology was for me was I could see how important communication was. And that was something that appealed to me. I could see how that interaction with the patient was so important, and that appealed to me. I could see how the oncologist treating patients had a big impact on the patient journey, not just in terms of outcomes, but also the interactions. So that appealed to me, and linked with that is definitely a caring speciality. I also, at the time, thought I didn't particularly fancy procedures. So I thought, well, oncology ticks that box. That said, if anyone's really into procedures, you can still do oncology. There's lots of brachytherapy, so don't rule that out. I also thought I didn't particularly want to be a medical registrar, and thankfully within clinical oncology, you don't have to do that. And then I guess I did have a sort of personal/family experience. So we all know that unfortunately about 1 in 2 of us will get cancer at some stage. And around the time of thinking what I want to do with my life, I did have a family member have a cancer diagnosis, and seeing how they were treated, I just found very inspirational, to be honest. And that again just reaffirmed I actually think that's something I want to do in my career. So disclaimer, I applied to clinical oncology and medical oncology. And when the time came of being lucky to be offered both, I thought long and hard because there's big perks to both. So I guess, yeah, I ended up picking clinical oncology, and we'll talk a wee bit more about that. So next slide, please, Jackie. So in terms of the clinical oncology training pathway, if we're just to think about it in a straightforward, simple way, this is what it looks like. So you run through from ST3 the whole way through to ST7. Now, obviously, it's a wee bit more complex than that, and during each part of your training journey, you learn some different things. So, for example, ST3 is now the Oncology Common STEM year. And something certainly I think most resident doctors, as they go through clinical oncology towards the end, start thinking about other things to do, such as out of program opportunities. It's not something I necessarily thought I would want to do when joining the program, but actually I wanted just to flag how great an opportunity it is to be able to take a year out, for example, go somewhere else in the world, learn a new skill, or also some people are very interested in research, and that's something that can be done. I think it's worth flagging that it's lovely having that option, but it's not necessarily something you have to do if you think that's not something that you want to do. And if we just go to the next slide, I'll basically outline what I have done, if that's helpful. So for a wee bit of context, you can probably tell from the accent, I'm from Northern Ireland. And it's quite common that although you'll be based in a particular region or deanery for your training, that you will work in different cancer centres in that region. So in Northern Ireland, we have two main units, the Northwest Cancer Centre and the Northern Ireland Cancer Centre. And you do your training really across those two different sites. And that's quite common no matter where you are. So as you will also see in my journey throughout training, it's very common, and you will work in different tumor sites. Okay, so you'll cover by the end of it all of the common tumor sites that a clinical oncologist could treat. So that includes 3 monthly rotations in lung, breast, lower GI, GU, gynecology, head and neck, etc., etc. And actually, just on making this presentation, it made me reflect on the fact that when you change where you're working, or the team that you're in every 3 months, it keeps things very fresh. It means you're constantly learning, and you never think I'm getting stagnant or anything like that in the role that you're doing. And it is genuinely quite exciting. It's constantly learning and interesting. And I guess the idea is that, yes, that's good that you cover all the sites and you can do exams, etc. But by the end, you should, in theory, be capable of working in any really of those sites come the end of training. So that's quite exciting. You'll also see in between the sort of ST6-7 step for me, I have taken this sort of out of program experience. I've done a fellowship in clinical leadership, which has been fantastic. And it's lovely having the option to do that in training. So next slide, please, Jackie. I think when talking about clinical oncology, I thought it was useful to think about a typical week. And for me, and for most of us in it, the variety is key, and the variety is what makes the job so enjoyable. So to give you an example of what things you would do in a typical week as a clinical oncology resident, registrar doctor, or consultant, you'll have radiotherapy clinics and radiotherapy planning time. And I really enjoy radiotherapy. And part of the reason why I really enjoy sort of working in that area is the huge impact that you have on the patients that you see. So you'll see some patients and work them up for a radical course of radiotherapy where you're aiming to get rid of their cancer. You'll also see some patients who may have metastatic disease that has spread, and they may, for example, be in pain. And you're going to see them to consider radiotherapy to see, can you help with pain, for example, so you can make a big impact. You'll have new and review clinics. So you'll see a patient referred to oncology for the first time. You'll see them take a full history, get to know them from scratch, and then think about what treatments may be suitable. You will have systemic therapy clinics. Now, in the past, not even that long ago, they would have been called chemotherapy clinics. But what is very exciting is that things have moved on and changed. So when we say systemic therapy clinic, we call it that now because we're not just giving chemotherapy. things like immunotherapy and targeted therapies have really taken off in a great way, meaning we have a lot more options in terms of what we can give our patients, which is really exciting. Most of us do on-call work, perhaps unlike what you would be used to before joining clinical oncology a lot. And actually, the majority of my time on call is done non-resident, in other words, giving advice from home, which is good. Uh, you will have some ward work looking after inpatients that have been admitted. And then there is teaching that will be part of your clinical oncology resident doctor program. And when I say teaching, that's teaching for you, delivered to you for you to learn. Okay, so it's not you giving the teaching. Can be if you want to. And what I've put in here is basically an RCR, clinical oncology job plan, for an ideal trainee timetable. And if you just look at it, so yes, you can see the weeks varied, but there's certain things in there, such as admin time, which you may not be used to before joining this program, but it just shows you that you're sort of working in a way it's very supported, and you're given time to do the different tasks that you need, which is great. That's also an example here of what would be a full-time sort of program or working week. And I think it's worth flagging that an ever increasing sort of percentage of our clinical oncology residents are working less than full time, and that as a whole is very much supported by the college and supported by the deaneries that you'd be working in. Next slide, please. So I put in this photo, as you can probably see from the white coats, it is a stock image. It's not a real life photo. However, I put this in really to flag and just to re-emphasize, personally, the favorite part of my week is my radiotherapy time. This image nicely flags the fact that radiotherapy work is basically like teamwork. So although you will be there as a doctor, there will normally be a physicist involved, a radiographer, sometimes nursing staff. There's a whole team involved in planning radiotherapy. And linked with what I was saying about the systemic therapies, a very exciting thing about radiotherapy now is that how we do radiotherapy now is completely different to how we did it 5 years ago, 10 years ago, 20 years ago. Things are evolving, and in a good way, so that we're having better outcomes and less toxicities and side effects from the treatment, which is great. So next slide, please. So I've already touched on the fact that there's lots of teaching given to you when in training in clinical oncology, and I really mean it. So there are extensive courses. I mentioned I'm really excited and interested by radiotherapy. Like most people, when they start their ST3 program, it's fair to say most people that start don't know an awful lot about radiotherapy, and I was certainly in that boat. And that did give me a bit of anxiety. I thought, is it normal to start life as a reg, maybe not knowing that awful lot about what it is you're now working in, but actually you're given all the training and teaching that you need in program. So extensive courses. Personally, I've attended courses run by Christie and Cardiff and Leeds, a whole range of fantastic courses. And you will, of course, have study day for that, self-study and budget, a financial budget for that also. There tends to be regional teaching days, local teaching, and the RCR have a fantastic website and platform that you can use basically for like online learning as well, including an RCR question bank. And the teaching that you will receive doesn't just come from your consultants that you work with. You'll have registrar teaching, radiographer teaching, and physicists are also very happy to help as well. So linked with that, if we could go to the next slide, please. I did just want to touch on the fact that when working in clinical oncology and training in clinical oncology, there are examinations. When I said I applied to clinical medonc, I did weigh up the pros and cons, and of course, I had a bit of thought as to, do I want to do more exams in terms of the extensive exams that was talked about in clinical oncology. Within clinical oncology, you sit FRCR Part 1 by the end of ST4, and there's 4 components. And I really wanted to flag this, during this talk, to say that although you see, for example, there's a physics exam, it's not what you think. Okay, so for example, you don't have to have done A-level physics. It's nothing to do with Einstein's theory of relativity. It's essentially physics that you should know and would need to know to do radiotherapy. So it's very practical. Okay, linked with that, the Part 2 exam is like a clinical exam. So 2A is a written part, and 2B is a practical part. And I'm basically saying this, that I went in saying I'm not sure if the exams are something that I'd be wanting. But if you click the next slide, Jackie, I actually won the gold award for the Part 2 exam. So I just basically wanted to say if I can do it, anyone can, and don't let that put you off. Next slide, please. So, as Louise kindly said, I am co-chair of the Oncology Registrars Forum. And if we go to the next slide, I've just taken a screenshot to show you that each region has a rep representing them on the ORF. And what we are is a resident doctor voice within clinical oncology. We discuss best practice, we flag any issues that there may be, and we essentially have a network from across the UK. And I very genuinely mean that the RCR take the resident doctor voice very seriously. They go over, they bend over backwards to help resident doctors in any way they can. And should there be any issues flagged, etc., they address things very quickly, which is fantastic. Next slide, please. I know Louise has already alluded to this, but one example of the fantastic work the RCR does for resident doctors is ATSM. So it's this essentially trainee resident doctor annual meeting, and it's fabulous. So there's talks, lectures, etc. given during the day. There's a dinner in the evening and a good night out. So it's a really lovely way of, yes, learning, but getting to meet people in clinical oncology from across the UK. So I'd encourage anyone who can to get involved next year. So what this is all about really is you thinking about your future career. And I've put in a few things here as to why I think clinical oncology is fantastic and you should consider it. So I guess for me, one of the most important things is the clinical work. As I said, it's varied, it's exciting, it's constantly evolving, and it's fantastic. The training pathway is well structured, very well supported. I've made reference to how things are changing, and artificial intelligence. Actually, the RCR and clinical oncology are leading the way among medical specialities in terms of using AI and also learning from it. And the RCR are running now an annual AI conference, basically representing that. I've already touched on how the RCR is great. So management-wise, well, oncology as a speciality, as cancer as an issue, is getting bigger. Waiting times are getting longer, and actually, there's real need for strong leadership. So, if management or leadership is something that may interest you, certainly think about doing oncology. There's a scope for private work if that's something you wish to consider, and there's very much a scope for research and other projects as well. So, next slide, please. So bringing some of these things together, I would propose that clinical oncology is a sustainable career. There's always going to be good work. We very much need residents and we need consultants. There's scope for less than full-time work and at times working from home. I can honestly say the on-calls are manageable and the ward work is manageable. And I think one tip I would definitely just say and give is to talk to residents or consultants around you. We're generally nice and definitely happy to help. And certainly when I was thinking of applying, as many of you may have done, I was experienced in the ward sort of job working on oncology, but the job that you do as a registrar or consultant is very different. I would say in a good way. So definitely talk to those around you. So on the next slide, hopefully there's my email. I'm more than happy to take any questions, not just today, but going forward. And I very genuinely would recommend clinical oncology to anyone who's thinking of applying. So thank you.
Thank you, David. That was a fantastic overview. Thank you so much for sharing your enthusiasm. And I completely agree that within oncology, we kind of combine cutting edge treatments, don't we, with that really patient-centered, holistic care and a lot of teamwork built in. I can say I certainly didn't do physics A level, and a lot of us didn't. So not something that you absolutely need to train in clinical oncology. You do get a lot of teaching to help you with the background science that you need. So thank you very much for that. We're now going to move on to Dr. Ruth Conroy, who's a clinical oncologist in the Christie Hospital in Manchester, and she's also our national recruitment lead, and she's going to talk to you about the ST3 recruitment process. So thank you, Ruth.
Thanks, Louise. So, hi, everyone. Just to echo, really, I guess what everyone else has already said, it really is a great specialty. I hate physics, but always hated it. Begrudgingly did it at GCSE, made a very clear point of not doing it at A level. and then found myself wanting a career in clinical oncology and realised that actually the physics was the favourite bit because it was very clinical physics. It made lots of sense to radiotherapy. So please don't worry about that. And I would also just echo some of the comments about variety. I was just thinking what I've done today, and I'm the training program director up here in Manchester. So I started my day with some kind of training related admin, and then I actually had a coffee with someone from the college talking about the global college and kind of training internationally. And then I had some radiotherapy planning to do, and then I had a clinic. So I've done loads of different things today and used loads of different bits of my brain, but at the heart of it is still the patients. So, and that's always kind of really important to me. So I love the fact that as a consultant, I can do lots of different things, but I always have a lot of patient contact. So that's been kind of really important. But anyway, enough about me. I'm going to tell you about the recruitment process. So just thinking about kind of the imminent recruitment process, I guess. So round 2 we've already had for 2025, but we do have round 3 coming up for 2025. So the post will be released any minute, and I think I've got the exact dates on the next slide that we'll go through for round 3. But just to give you a rough idea, if you're not thinking of applying for round 3, if you're thinking more for kind of next year, that it's usually around November time that we'll publish kind of vacancies that are available. Applications are going to close by roughly mid-December, and then we look to interview kind of early April time, and then vacancies usually out towards the end of April and May next year. But if we can go on to the next slide, please, Jackie. So just the details, just in case people are looking to apply for round 3 this year, which is jobs to start kind of February, March 2026. So on the 28th of July, we'll have all the vacancies out. So you'll know what's available across the 4 nations. And then you'll be able to apply from the next day. And the applications will close on the 14th of August. And then you'll have time to upload all your evidence to the system so that then we can go through that. We have a team of people that will verify all the evidence that's on there, and then we'll send out the invites to interview 24th of September, and that interview date is the 8th of October. And we are aware that that is a Jewish religious festival. So if anyone is impacted by that, we will be able to accommodate another day for interviews. So please do let us know. And then we'll have initial offers out on the 21st of October. So that's just the dates for the next round. And literally those change by a day or 2 each year. So it's a very similar kind of time of year every year. So if we can move on to the next slide, please. And the key eligibility criteria are that you've got to be able to demonstrate the capabilities that we would expect at end of IMT2. So that doesn't mean you have to have done IMT2 here in the UK, but it's if you can demonstrate kind of equivalence. So in old money, kind of, you know, as a second year SHO, a kind of senior SHO. And then the other really key thing is that you need to have your MRCP or MRCPI by the time that the interview offers come out. And I'm afraid, I know it can be a pain sometimes with the MRCP and dates and things, but that is a real key thing that you need to have your MRCP. And we've learned from a lot of experience that it's quite important to kind of have that, because often people struggle if they've not got the MRCP. We do try and interview all eligible candidates because we think it's really important to be able to interview people, because we appreciate it's sometimes hard to sell yourself on application forms and things. So as long as we have the capacity, we hope to be able to continue to do that. So please don't be put off from applying if you think you might not have a great application on paper and things, because we do try and interview everyone if we can. So next slide, please. So as I say, the self-assessment is not the be-all and end-all of things. It only forms 15% of the overall score. We are very similar to the other medical specialties. It's just that we tend to give higher marks if whatever the work that you've done is kind of specifically related to oncology. When you're doing the self-assessment, please make sure that you put evidence for everything that you do. There's nothing more upsetting than when you're verifying evidence and someone says that they've done this amazing project and then they've forgotten to put the certificate or whatever the evidence is, because we just can't score people on kind of what they've said. We really need evidence, because all the scores will be checked by a consultant clinical oncologist. To say we have a big team of volunteers that help us do this. And if you think you've not been marked fairly, we're more than happy to review that. There's a very robust kind of appeals process. So please don't let that put you off applying. It's only one small part of the whole process. And we'll talk a bit more about how you can kind of score on that. But what I recommend is have a look now, and then you can see kind of what the scoring is and start thinking, because there might be things that you've forgotten that you've done that you're like, oh yeah, I can use that kind of thing. So the key thing is to try and plan ahead, because there are some things that you will be able to do now, even potentially for the upcoming round 3, to be able to score you points. So the more organised you can be, the better, really. So next slide, please. So there are some kind of key things that you might not be able to change at this point. So at the moment, we do ask you about your MRCP, and you'll score a certain number of points if you've already got the full MRCP, and different points according to how much of the MRCP you've got. But as I say, you don't have to have it at the time you're filling in this form. You just have to be able to potentially get it by the time the offers come out. You can score for postgraduate degrees and qualifications. You can score for presentations and posters, and there's potentially still time now for you to do some work and be presenting that kind of departmentally, and things that you would be able to score for. People score for publications, and that doesn't necessarily have to be a complete new research article in a super high impact journal. If you're doing good quality improvement work, audits and service improvement in your department, these are things that you can get shared and potentially score for as publications. You will score for your teaching experience, so teaching that you have done, whether that's kind of bedside teaching of medical students, or these days, a lot of people have helped create teaching programs in their local hospitals and things. So there's lots of different things that you can do to score there. And you will also score for your training in teaching. And again, just between now and the next round, you don't have time to go off and do a full PG cert, but there's lots of online courses that you can do that potentially you would be able to score for. So there are things that you can really go and do, after tonight to start looking at how you're going to score here. Obviously, we score for quality improvement, especially if it's an oncology related quality improvement project, and you also get a score for leadership as well. And again, that doesn't necessarily have to be medical leadership. You may have been really involved with the sports club at medical school, and you can show how that gave you a range of skills in being organised and delegating and things. So there's lots of things that you can score for. So that's the website to go to, the clinical oncology self-assessment guidance. If you literally just put that into your search browser, it will give you all the information that you need so that you can really start thinking now about what you're going to put. And even if you can't put something for each box, do not worry. Please, if you're keen, still apply. So next slide, please. So when it comes to interviews, as I say, we try and interview everyone, and there are 3 stations. So there's a clinical station, an ethics kind of governance station, and a portfolio station. And you don't necessarily run through them in that order, and we're not expecting you to know everything at this stage. We know that most people going into clinical oncology haven't really done clinical oncology before. They haven't got a lot of radiotherapy experience and things. So, we're looking at you at the level, as I say, at the end of IMT2. You will have 2 interviewers for each station, so that everything is nice and fair and balanced. and it'll be 2 5-minute questions for the clinical station, another 2 5 minutes for the ethics, where we also bear in mind your general communication skills, and then 2 quick 5-minute questions about your portfolio and your experience of clinical oncology. So if we can move on to the next slide, please, Jackie, we'll kind of go through. I'm not giving any answers away here. I'm not going to tell you all the interview questions, but you know, I think most people can have a good stab at what we want to be asking. We're going to think about oncology patients, and we're going to think about an oncology patient that isn't unwell. So you can probably bet pretty good money that an oncological emergency is going to be in those questions, whether that might be a malignant spinal cord compression, febrile neutropenia, hypercalcemia, brain metastasis, and things. You know, you can think of common things that you may have experienced, or, you know, a quick Google of oncological emergencies will give you a wealth of knowledge there. And it's just about us seeing or hearing how you approach the patient. You know, what are you going to do? Can you come up with differential diagnoses? Can you come up with a generally sensible management plan for someone at the end of IMT2? So it's not a comprehensive cancer management plan. I don't want you to tell me the dose of radiotherapy that you need to give to the spinal cord compression, but I want you to think that spinal cord compression might be something that an oncology patient could have, kind of thing. So, you know, we're not looking to catch you out. So if you have a think about common oncological emergencies, you'll be standing yourself in good stead for a lot of the clinical questions. Next slide, please. The ethics scenarios, again, we do not want to catch you out. We want you to come and work with us. We want you to join our specialty. We all love it. We want you to come and love it. But we just need to make sure that you're thinking generally about the right things. So again, you know, this is by no means an exhaustive list, but what kind of things crop up quite commonly in oncology? Well, we have to think about consenting patients for treatment. We often have to think about what happens when maybe patients are reaching the end of their life and we don't have a lot of treatment options available. We work in the NHS with colleagues, you know, we're parts of a team. What do we do if you're worried about a colleague's behaviour? What do you do for patients confused and things? So just common, maybe tricky scenarios that you've probably come across a million times in your day-to-day life. So just think about how you managed those and how you'd go through these difficult situations in a kind of step-by-step process. And next slide, please. And then the portfolio, as we've all said, we think it's great. We want you to kind of tell us why you think it's great. What is it that's kind of sparked your interest? And we appreciate that not everyone might have had the opportunity to have an oncology rotation in their training so far, or spend a massive amount of time in kind of radiotherapy departments. But have a look on the RCR website, you know, have some understanding that, oh yeah, I know there's exams, don't worry, I'm okay with that. And I know that I hate physics, but everyone's told me physics is okay, so I'm not going to worry about it, can I? Just show that you've been interested and you've researched things. And, you know, I'd really echo David's comments about try and talk to one of the resident doctors. If you can, you know, the ORF reps are happy to be contacted, or get in touch with your local training program director. They'll be able to put you in touch with someone, because often the job you see, if you're looking after oncology inpatients on the wards, is nothing to do with actually the real life job. It's very, very rare that I have an inpatient. You know, we're really very much an outpatient specialty. So try and get a feel for that. You know, most medical jobs will have at least some link with oncology. So try and get yourself to an MDT, maybe just have some understanding, so that when we ask you why do you want to do it, you can say, well, actually, I met this person and they really liked it. And that really kind of shows us that you're keen and that you've really thought about what this job is going to involve. Next slide, please. So as I say, things that you can do in preparation, talk to us. You know, I'm happy to be contacted. There is tons of information on the RCR website. Have a look at your local deanery, as was website. If you go on the NHS England websites, there's tons of information about your local training programs, so that you know how those work. The contact details for the training program directors are usually there. I think genuinely we are a really friendly specialty. I don't think I'm just saying that. You know, relatively speaking, we are a small medical specialty if you think compared to kind of cardiology or, you know, or radiology, our kind of counterpart in the college. We are small, so it's a small network, and if you're having to email us from a different area, chances are we know someone in your area, or we know someone who knows someone who's going to be happy to help you, kind of thing. So please do reach out. People are very keen, and I think we're all quite evangelical about the specialty, really. So we'd be very happy to help. So next slide, please. I think, yeah, sorry, just another plug for Atom. I didn't have a photo of everyone, but these are four of the resident doctors, sorry, three of the resident doctors and one of the LCR staff from, you know, our programme in Manchester. And it's great that, you know, they just got involved. They did all this off their own back. There's loads of opportunities to get involved in all sorts of different things. So, yeah, please, you know, come and join us. Next slide, please. That's everything. Perfect. Thank you.
Brilliant. Thank you very much, Ruth, for that insight into the application process. So thank you very much for that. And we're going to move on now to Dr. Martin Lear, who's a ST3 doctor in clinical oncology, again from Northern Ireland. We've got a good contingent from Northern Ireland in our speakers today. Having recently been through the process as an applicant, you're going to give an applicant's view. So thank you very much, and I'll hand over to you, Martin.
Thank you for giving me the opportunity to talk. As you say, I've recently been through the process. So I think in addition to what we've heard from the other speakers today, there will be a bit of overlap, but I want to talk about the approach I took in preparation for the application process. So next slide. So I suppose thinking about the application process in itself, preparation is key. What I would suggest is start early, identify the appropriate deadlines which have been shared with us and will be available online, and think about the approach you're going to take to the application process. And that really will focus around thinking about the self-assessment and thinking about obtaining evidence as part of your self-assessment. And how you're going to structure and approach your interview process and your interview preparation. Next slide. As I say, preparation is key. Start early, and as has been alluded by the previous speakers, it's important to reach out to people like myself or David or other trainees that have gone through the process who'll be willing to help you in your preparation for both the application and the interview process. And next slide. So it's really important to think about getting involved. You may or may not have had a rotation through an oncology department, and if you have, that's good. If you haven't, it's important to think about trying to identify an opportunity to spend a taster week within an oncology department, and that will give you an indication as to what it's like to be a clinical oncology trainee and what it may be like as a career. You have opportunities to spend time in radiotherapy planning, spend time as part of the wider MDTs, so with physicists and radiographers. Have a look at what it's like to be in an oncology clinic and what our day-to-day clinics are like, MDTs and ward rounds, and just the general spectrum of what the job will be like. Having done a taster week, it really is a commitment to specialty, and you will have the opportunity to participate in various consultations as part of that, and that may provide you to have a reflection upon certain cases and patient interactions that you've experienced, and these will lead inevitably to good discussion points at interview. And I suppose by undertaking a taster week, it also provides you with the opportunity to potentially get involved in some research or audit or QI as part of your application process. And it really is a good opportunity to gain an insight into the evolving area of research within clinical oncology. And next slide. So it's already been covered by the previous speaker, but thinking about your eligibility as part of the application process, so having achieved IMT2 or an equivalent level of competence, and having achieved MRCP by the time of application, and it also doesn't require IMT3 as was previously said. And if we can move on to the next slide. So self-assessment is a really important aspect of the preparation, and it's really important to have a look at the domains in detail. There will be some that will be more defined than others, having MRCP, having additional degrees. But if you look at the scoring components for the various other ones, for instance, prizes, there will be certain aspects that you can think, well, what is achievable between now and the application process? It allows you to have the opportunity to identify your strengths in your current application and also look for any areas where you could improve upon. It's important to be realistic of what can be achieved between now and the application process, and it's also important to think about where areas outside of medicine can be really important. And I think also that's very important for the leadership component of the self-assessment process. If you have spoken to someone who's gone through the process before, it's important to perhaps ask them to have a look at your scoring system to make sure that you're scoring yourself appropriately and not overscoring. Or if you have the opportunity to be involved in an oncology department, there may well be some of your consultant colleagues that are involved in the self-assessment ranking process, and it might be useful to speak to them to see whether or not you're scoring yourself appropriately during that period. And next slide. So as I say, don't overscore, but be important to really sell yourself as part of the process. Review all components of the scoring, because it's particularly important, for instance, if you've done an element of QI, whether or not there's an opportunity to get involved in a second cycle or additional cycles, because this may improve the scoring element of your self-assessment domain. And I mentioned ensure adequate evidence, and ensure that you do that in a timely fashion to make sure that you've got the evidence compiled for submission of the evidence after you've submitted your application. I think most consultants would be willing to help provide you with the appropriate evidence so that you will be eligible for obtaining the score that you've already self-assessed yourself for. And next slide. So the interview process has been covered in some degree, but it's a fairly streamlined process. It's an online process, and as you mentioned, there's 2 clinical scenario stations, 2 ethics stations, and 2 portfolio stations. It's a very swift process, and in the next slide I'll talk to you a little bit more about how I prepared for those and what I think is important to cover. Next slide. So clinical ethics stations, 5 minutes is really not long. It's important that you think about some of the topics that might come up, as we had mentioned, oncological emergencies, the different types of disease process that you might encounter in an oncology patient in an oncology ward. It's important to have a good structure in how you would approach those patients, and that it's systematic and that there's appropriate safety element to it, and you're working within your own degree of competence or your level of competence. Thinking about the ethics station, as mentioned previously, think about issues of consent, working with difficult colleagues, working within your own level of competence. It's important to practice, and certainly if you have the opportunity to speak to someone who's gone through the process before, I'm sure that they'd be willing to take the opportunity to sit down with you and practice going through those scenarios, so that you feel that you've got a good systematic component and that you can achieve all of the necessary domains in the marking scheme within a short period of time, within the 5 minutes. And next slide. Portfolio station is a really important opportunity to discuss what you've achieved in your CV so far, and it really is the opportunity for you to think about how you've scored yourself in the self domains. I think it's important to be prepared to discuss your achievements, discuss why you're happy with what your achievements are, what are significant achievements in your career to date, what are significant achievements outside of medicine. I think it's an opportunity to sell yourself and use it as a platform to discuss why you want to do oncology, what you have done in the past to demonstrate your commitment to the specialty. I think it's important to not just view yourself as an applicant in the process, but to present yourself as a future colleague in clinical oncology. I would encourage you to read about the the domains of clinical oncology and what the average day looks like, what the average week looks like. David had quite a good overview there of what the training curriculum is like, and be familiar with the various milestones that are required to meet, the differences between that and medical oncology, for instance. and just think about current achievements, things that are fairly topical at the moment. The RCR website is quite a good reference point, just to demonstrate that you have a wider interest in clinical oncology, that you are prepared to read around the areas, and that you're passionate about the area, and that you can sell yourself appropriately. Next slide. And that's just really all I wanted to say. Thank you.
Thank you so much, Martin. That was really, really good talk through about how best to prepare. Yes, I think, as everybody has said, we're a friendly specialty. Come and talk to us. Come and spend some time in the department to get to know what life as a clinical oncologist looks like. As Ruth said, and everybody has said, great variety in our day-to-day work. We do see patients as new patients. We talk about the treatment options. We guide them through their cancer journey. We arrange radiotherapy, systemic anti-cancer therapy. We attend multidisciplinary team meetings. So we really, no day is the same, really. We really have a very varied working life. So thank you so much. That concludes all the talks. And we're going to go to the Q&A session now. I think we've got Keela, who's been keeping an eye on the questions. And I think what we'll do, if are you there, Keela?
I'm here, yeah.
Brilliant, fantastic. And so I don't know if you want to read out some of the questions, and then we've got the team here. For those that weren't there at the very beginning, we've got Dr. Satinder Jagdev, Dr. Simon Pacey, and Dr. Ben Pickwell-Smith from Medical Oncology, who will be able to talk about some medical oncology aspects as well. So if you have got questions, do put them into the chat. And then over to you, Keela, if you're able to.
Just to say, we have a Q&A feature on the webinar, so if you can pop any of your questions into there, and if the speakers could just take a look at them and see if there's anything you could pick up on. But I'll just go from the very top. So we have a question from Alex regarding LTFT. Is it competency-based or time-based at ARCP? And is this deanery dependent?
Do you want me to take that one with the
yes,
TPD
yeah.
hat on?
Yeah.
So it will start as a time-based thing. So your first ARCP will be based on time, but obviously as you get through the program, if it's felt that you're developing competencies at a quicker rate, then ultimately it is a competency-based curriculum. So we have a lot of resident doctors that officially it's called accelerating their CCT date because they've been in program for a number of years but less than full time, so feel that they've managed to meet their competencies. So we have a lot of less than full time trainees who don't necessarily do the whole time equivalent time, and likewise for people who do out of program time, sometimes that gives them experience that they maybe didn't fully appreciate that they'd get out of program. So sometimes they will move their CCT date as well, because ultimately it is about, have you met those competencies? So there's national guidance on this, and I think the national guidance is that realistically you're probably not going to be able to accelerate your training by more than 25%. I think so. In my experience, it's usually somewhere between about 6 and 12 months, kind of whole time equivalent. People have moved things, and that needs to be discussed with your educational supervisor and your training program director kind of along the way. It's not something that should just be thrown in at the last minute at your final ARCP because there's a job that you fancy coming up. It should be a planned and agreed thing, and ideally it mentioned at your kind of penultimate ARCP, if not before. So hopefully that answers that one.
Thanks, Ruth.
Thank you, Ruth. Have we got any other questions, Keela?
Yeah, we have a good few. So have acceptance rates for international students in the UK dropped? And then is it getting much harder to specialise as an IMG?
I think that might be another one for you, Ruth, possibly.
Yeah, so I mean, I apologies because I don't have the exact figures, but my experience of doing the self-verification and the interviews and things would say that actually we still get a lot of international graduates applying. And I think perhaps unlike maybe some other earlier stage medical specialties that are oversubscribed, and obviously there's been a lot in the press about that at the moment, we're not oversubscribed. So, you know, we are keen to get as many people as possible, and, you know, would actively encourage international medical graduates to apply, because often, you know, you bring in a wealth of experience. And I think increasingly the college is aware of some of the challenges that IMGs might face, kind of starting work in the NHS, or maybe kind of transitioning over. And so I think we're quite good, really, as a specialty and as a college, as really kind of helping IMGs. And I don't see that as a barrier at all, to be honest. You know, it's not something we're happy to accept everyone. The more the merrier.
Lovely, thank you. And I don't know if Simon is here, Dr. Simon Pacey. I can't see you on the screen, but you're the...
Yeah, I'm hiding here. Hi, Louise.
You're hiding, okay. You're the recruitment lead for medical oncology, aren't you? So are you happy to endorse what Ruth has said? Any further comments on that?
No, I think very spot on. I haven't seen the data on sort of acceptance rates, but I agree we see plenty of applications with alternative certificates and career pathways. I think the reality is it's just getting a little bit more competitive as people are sort of stacking up at IMT level. But we would certainly the same encourage people to apply, and I don't think you're disadvantaged coming from outside of the UK. The issue is listening to your colleagues on this sort of webinars and writing your application so that you catch the points that you're entitled to in the scoring system.
Thank you. Keela?
Perfect. So the next one is about OOP, so that's out of program. So in regard to OOP-E and OOP-OR, this person understands trainees are entitled to up to 3 years for OOP. Is this 3 years for each, or shared across the various OOP subtypes?
I think we might go back to Ruth for that one.
Oh, yeah, I was going to say me again. So do you know what? I can't think of how it's actually worded in the Gold Guide off the top of my head, because my experience is the vast majority of residents only do one. So I've never come across anyone who's done kind of an out of program experience for so long and then wanted to do research again, kind of thing. So I'm pretty sure that's kind of across the board, because people don't want you extending your training for too long. You know, people do want you to get through your training. Certainly for out of program research, it can be extended to up to 4 years. You know, we've had a lot of resident doctors doing PhDs, and it's sometimes taken 4 years, but I can't imagine having 3 years for an OP and then doing another 3 years for an OPAR. But again, medical oncology may.
I think OOP-E is a maximum of 1 year, and so occasionally you do OOP-E and then you can go into an OOP-R because it helps you get the experience for an MD PhD. And as you say, Ruth, and the OOP-R is 3 years, which can be extended as per your local deanery.
Lovely, thank you. And I can see Satinder's got your hand up, which was great, because I was going to come to you. Yeah. So Satinder is my equivalent in medical oncology. So thank you, Satinder.
Thanks very much, Louise, and hello everyone. Just really to add to that the length of time really depends on the program that you're applying for in terms of going out of program, particularly for OOP-E, and sometimes residents may choose to do a leadership program, which might be just of a year's duration. Other times they may do an education certificate. Again, that might be 1 or 2 years, and then sometimes going out for a higher research degree, you know, that might be 2, 3, up to 4 years. So it depends a little bit on what it is that you're aiming for and what you're applying for in terms of going out of program. I think I just wanted to add.
Yeah, thank you, Satinder. That's great. And a lot of people ask about what's the difference between clinical and medical oncology, don't they? So, I mean, do you want to just take a couple of minutes just to talk about the medical oncology training?
Yeah, absolutely. Always happy to talk about medical oncology.
Brilliant.
So the focus of medical oncology really is on the systemic anti-cancer therapies, and so that's thinking about drug therapies, cellular therapies, various kind of innovations in terms of the pharmacological therapies, as opposed to radiotherapy. So we don't give any radiotherapy at all. And as such, the competencies in our curriculum are different to reflect that. There is a research aspect to it as well in terms of the core capabilities, but also quite a lot of our trainees will get some experience in research, although it's not mandatory to do a research degree. And in terms of the day-to-day work that we do, the training program is 4 years rather than 5. And we have one kind of exam that people take from ST5 usually onwards. They usually get a good couple of clinical years under their belt and then do it, because it is very clinical based, the exam that we do, and that just has one paper from any time from ST5 onwards. And so there are differences in the structure of training. I think as was in one of the previous slides, I think the first year of both clinical and medical oncology training is common to both programs. So when you go in as an ST3, you will be doing the same regardless of whether you're doing clinical or medical oncology, and in terms of the courses, etc., and the experience, that should all be pretty much kind of the same across the board. And then it's at that ARCP, once you've got through your ARCP at the end of year ST3, you then go into your medical oncology program, or if you're doing clinical oncology, into the clinical oncology program. But I guess in terms of the work, really, it's again much like clinical oncology. It's fast paced, it's developing all the time. We're building on the research that's coming through, and very much involved in bringing new technologies and new therapies to the patient through clinical trials, which forms part of our day-to-day work. And then there are many avenues to be able to branch off into, such as research, teaching, education, management, etc. So again, much like clinical oncology, a very varied pathway, and something for everybody, I would say.
Brilliant. Thank you, Satinder. And there is a medical oncology webinar coming up in the near future. Is that right?
Yeah, you can see the details behind me, and there's a QR code on Simon's slide as well. But that can be accessed through the Association of Cancer Physicians website, and that's on the 14th of July. And we look forward to seeing you there, and we can go into a bit more depth about the training and what it involves to be a medical oncologist.
Lovely, thank you. Keela, have we got any more questions?
Yeah. So we have, if I have more than 3 months of teaching experience from foundation training that enables me to score max points, can I carry this forward for the ST3 application?
Yeah, definitely. We're not looking at necessarily when you've done things. It's just, if it's relevant to the application, that relevance doesn't go away. Hopefully you don't forget it, kind of thing. So yeah, we won't be looking at what you've used on other application forms or anything like that. So anything you've done throughout your life, will definitely be considered.
Brilliant, thank you.
Thank
Next
you.
one.
So this person has asked, could you please give some examples for PG certs that we can do?
I mean, I guess with that one, the internet is out there. There are tons of PG certs. There's all different universities do all different kind of things. So it's finding what you're interested in. You can do a PG postgrad certificates in leadership, in management, in teaching. There's lots of different ones. So have a look around. Some are more in person, some are more online. So find something that interests you. Basically, I think the world's your oyster on that one, I would say.
Lovely, thank you. Keela?
So the next one is, in the second station of ethics in IV, should we expect research related questions?
Sorry, should I go again? Apologies, you fed up on my voice. So no, I mean, we wouldn't expect anything research related, as I say, that you wouldn't expect to be asked as an SHO. So, for example, we might ask you about, say, what does it mean to take informed consent? We have to take informed consent to get people involved in research studies, but obviously consent, informed consent is relevant in lots of different areas of medicine. So you wouldn't be asked something very niche to kind of research. It would be in a much more general way, so I wouldn't worry about that.
Thank you. And Ben? Thank you, Ben.
Sorry, I was just going to come in and correct me if I'm wrong, but when I had my clinical oncology interview a few years ago, there was, although it could have been the medonc, there was kind of general questions about what do you understand about phases of clinical trials. Again, as Ruth says, you don't need to be an expert by any means, but having that basic understanding of the phases of clinical trials. And in both specialties, I got asked about an exciting piece of research. So obviously not expecting you all to have an in-depth knowledge of the latest research, but thinking about an exciting trial and having read about a little bit. I'm not sure if that's fair now because this is going back a few years.
Yeah, I mean, certainly we wouldn't ask that now, but obviously if in the portfolio station someone might say, well, I heard about this trial in the press and that was fascinating. So yeah, it would only be in a kind of general term if someone wanted to bring that in. Yeah. I'm guessing it's probably the same in medical oncology as well.
Hard to be exactly prescriptive. I think the point to really emphasize, you've already said, and you guys have said it, is we're looking at end of IMT2 level. So we're not expecting you to show 4 years, 5 years of hematology oncology. And if you did say that, then you need to show what you've done with that time. So it actually almost makes it harder. So I think following Ben's point up, it's, understanding the more general points about consent, not necessarily the detail of what we might be consenting for, but the principles it's founded on. That will get you good scores. Whether you know the ins and outs of particular things might just be the luck of the jobs you've done, right? So I think the questions are there for a discussion, and I was thinking about that actually, Ruth, when you were talking about the clinical stations. Again, we're looking for sort of safe pairs of medical hands. Actually getting into the detail of the oncology, it might be an oncology scenario, but actually to some extent I think we're moving away from those a little bit. So it is again realizing that people are applying coming from a gen med background.
Thank you. Yes, and I agree. In the interview process, we really just want to know that people have kind of made an effort to find out what the specialty is, and that they've maybe visited a department, and so that they know what they're applying for, and that and shown an interest and with clinical skills at the level of IMT2 really. So that's exactly what we're looking for. Thank you, Keela. Back to you.
Perfect. Yes, the next one is the ATOM meeting for trainees only?
I think that might be one for David or Martin. So.
Yeah, certainly, Jackie, you can keep me right, but certainly previously it was, so when we say trainees only, there are consultants who tend to give presentations and interact with us, but it's really oncology registrar doctors is sort of the target audience. So I guess we're highlighting it today because once you of course get into clinical oncology, we want you to come and attend. Yeah.
Thank you, brilliant. Keela?
Perfect. So the next one is, do you need to provide evidence of your taster week?
So by all means you can put it on there, but actually when it comes to interview, the people interviewing you aren't looking at your application form. So the kind of self-verification is scored completely separately from the interview. So when people ask you, what have you done? Obviously, I can't encourage anyone to lie, and I don't want anyone to say they've done a taster week when they haven't. But actually, we don't. We will just want you to tell us what you did on your taster week, so it will be very apparent if you did it or not. But you don't actually have to have any evidence for it because at interview we can't see that evidence. But obviously, if you have done it, you may well want to put that on your kind of self-assessment form, or at the very least mention it on your application form.
Thanks. Keela?
So Yasmin asks, do intercalated MSc/PhDs count for the additional degrees in the self-assessment?
Yeah, definitely. And as I say, if you go on the website, it gives you a little bit of a breakdown of what we mean by kind of additional degrees, and we'll explain to you what you'll score depending what you've done. But yeah, certainly intercalated would count.
Perfect. So the next one is, I am a basic specialist trainee in the Republic of Ireland, finishing my 2-year training in July 2026. I will be giving BST certification in July 26. Can I apply for round 2 selection in 2026?
So yeah, because that's when most people, often a lot of people are applying when they're in IMT2, expecting to finish in the July and take up the higher specialist training post in the August kind of thing. So that would fit, as long as say it'll be the MRCPI that'll be particularly important there.
Thanks.
And so this next person has 2 questions, so I'll just read them both out, but if you need me to remind you, just let me know. The first is, can the application timeline be displaced again? And the second one is there a work-life balance in this career path?
So I wonder if that's supposed to be displayed. So I don't know, Jackie, if you can maybe put that up. I don't know if you want the general one or the specific round 3 one, but maybe put the round 3 up for this year, because it gives a rough idea.
Sure. So.
I mean, I'm happy to say work-life balance for me personally, definitely, because you can take on loads of extra stuff if you want to, or you can not do. And I'm probably fairly unique these days that I work full time, because so many of my colleagues don't now, because they've got other interests doing lots of other things. So I would say definitely. Obviously, Louise, the others, how do you guys feel?
Lovely, thank you. Maybe we can bring Martin in as ST3 to talk about work-life balance as well.
Yeah, I think the work-life balance is very good in comparison to general medical rota, and David had highlighted the working week. We do have scheduled times for administration, for radiotherapy planning, and a lot of that is quite protected, and it is good. And I suppose in addition to ST3 year and getting to grips with clinical oncology, I've also been a subdeanary fellow for oncology within the Belfast Trust. I've undertaken a PG cert in clinical education, and I am an OSCE examiner at Queen's University Belfast. So I'm able to do all of that while trying to master ST3. So I think the work-life balance is quite good.
Lovely, thank you. I think we're trying to get the timeline up. I don't know if Jackie's able to do that, but the timeline should be on the website. Actually, if you go to the NHS England website, they should be on there. But if you're able to show that, Jackie, and while you're doing that, Keela, do we have any other questions there?
Yeah, we still have a good few coming in. So this is from Ron. I have a master's in med ed. Can I score that in master's qualification, or would that score only be in the qualifications in med ed in brackets, which requires a PG cert?
Is that another one for Ruth or Simon?
It's another one that's going to hurt my brain. So I guess that you would be able to score that in both, because it is a postgraduate qualification and evidence of teaching and training. And I think you are scoring slightly different things in kind of each of those, because it's not just about your teaching experience, it's about your commitment to kind of doing something at a higher level. So based on our scoring criteria as it stands at the moment, you will be able to score that in both, I'm pretty sure.
Okay.
I don't know how that works in MedOnc here.
Simon?
There's something niggling at me about that. We used to have that phrase about, and it was an education degree that you couldn't count in 2 places, but I think you're probably right, Ruth, because I think it changed. What I would say is the bits that I was always very bad at reading, the notes that that get published alongside to explain what you score yourself, really do read those and make sure you're following the PRSO guidelines, because the notes are really, really detailed and they'll probably explain it. So if we're slightly out, but I think you're right. I think it's changed now that so you can put education qualifications in different sections.
And this might be exactly the kind of thing that you might put in, and then someone who's verifying it might come to us as leads to say, well, can you check that? And no one's going to accuse you of lying or cheating if you've perhaps overscored, or sometimes, you know, underscored as well. We'll look and go, actually, you could have scored in this other bit for that as well. So don't worry, you know, don't purposely overscore yourself in everything, but don't worry if you're not quite sure. We will look at that. As I say, you know, it is consultant colleagues looking, and they will have all the scoring criteria there. So, you know, we do take a lot of time and energy to make sure that everyone gets the fairest score, and we generally kind of score at the upper end rather than the lower end and give people the benefit of the doubt, you know, if we possibly can.
Thank you. Keela?
Yep, so the next one is, how important is research or publication for application?
It's by no means essential that, you know, really for research and publication, you'll score, you know, in the scoring domain for publication, and then potentially in the scoring domain for presentation as well. So there's definitely people who will not score in those areas. But as I say, that's only overall, that self-assessment is only 15% of your application. So you can still, you know, potentially you could score 0 at self-assessment, interview well, and still be offered a training post. So it's by no means essential, because we appreciate that often at the end of IMT2, people maybe haven't had the chance to do it because they've been busy focusing on MRCP and different things. So, you know, please don't let that put you off.
Thank you. And if you haven't had the opportunity during IMT, but you are interested in research, then oncology is a very good specialty to go into, because there are opportunities during the training. So thank you for that. Keela?
Yeah, perfect. Just to flag to you, Louise, we have about 10 questions left, so I know we're just about to run out of time. I don't know if you want to go over, or what your plan is.
Is the webinar going to finish automatically, or are we able to go over?
Yeah,
okay.
Jackie's given a thumbs up there.
I think so. We won't take any more new questions, but we'll try and rattle through the final questions, and then we'll close the webinar.
Yeah, perfect. So the next one is, apologies if this is outside the scope of this discussion, but I'm looking into QIP ideas. Are there any resources on the RCR or other websites where I can see what are the usual QIPs my current workplace can benefit from?
Is anybody able to take that?
I mean, I think I'd talk to your colleagues. So in terms of scoring your QIPs for your self-assessment, if it's oncology related, you will score more highly. If you're the lead on it, so, you know, this was your idea and you've kind of managed everything, the data collection, the writing up, the presenting, you'll score more highly. And if you've completed the audit or the QIP cycle, so you've done kind of 2 rounds to see what your intervention showed, you will score more highly. So I'd have an ask around with your colleagues and things, because you want it to be something that's meaningful. So people close to you will probably have more of an idea what's going to be meaningful to your department, kind of thing, so that you're not just doing it as a tick box exercise, you're doing it to really make a difference, kind of thing. And as I say, you score more highly if it's oncology related, but you still score even if it's not oncology related.
Thank you. Next one here.
Yeah. So this one is, I have an MBBS and MD in radiotherapy and oncology from India and working as an independent consultant. I want to migrate to the UK age 40. How can I proceed and what are my chances? Thanks.
Okay. So if you want to enter oncology training, either clinical or medical oncology training, you do need to have MRCP to do that. So if you've trained but haven't got MRCP, then there might be opportunities in local centres to do, for example, clinical fellowships or locum posts, that kind of thing. So there are opportunities to do that, but in order to enter the specialty training, which is what the webinar today is about, you would need MRCP. Is that the same with medical oncology as well, Satinder?
Yeah, so you would need MRCP or be able to demonstrate something equivalent, and I guess it depends on the situation for this person, you know, where if they've gone through actually a whole load of training and are qualified up to a certain level, then you know, I guess they need to think, is it specialty training that actually they need to do, or do they need to look at an alternative route like the portfolio route, for example, to become a consultant in the UK. So I guess it's very situation dependent, and certainly, you know, on the medical oncology side, any of us are happy to be contacted, and I'm sure you would be open to that as well, Louise and Ruth.
Yeah, I was going to say, just sorry, Keela and Louise, because the next question is MRCP a must-have a training job? Could FRCR clinical oncology be sufficient to apply for international applicants? And I think we get in a little bit away, because what we're talking about here is you're applying for an ST3 position. So, you know, a brand new trainee in clinical oncology. I think some of these questions a slightly different, where you might be wanting to come in at a more senior level, perhaps looking at the Caesar route and things. So it's probably best to have a look on the RCR and the Royal College of Physicians kind of website for guidance if you want to come in at that different level. I think that's probably the fairest and quickest thing to say for now, if that's okay, Louise.
Thank you, lovely. Keela?
Yeah, perfect. So kind of off the back of that, the next one is I finished FRCR oncology and have a master's degree and doctoral degree of clinical oncology, but from outside the UK, and have no NHS experience at all. What ST level would be applicable to me, and are these qualifications enough to qualify me to work in Ireland as well?
So I'd be looking at fellowships there, I think, if I were you, rather than necessarily applying to be a trainee, because you're essentially possibly able to demonstrate that you've done your training. So maybe a fellowship to get some NHS experience, and then perhaps looking at the Caesar route, I'd say. And I don't know all the details for Ireland, but I suspect it's probably fairly similar. I don't know if anyone else knows for Republic of Ireland.
We're not sure. Obviously, we're a UK training scheme, so we have Northern Ireland, but the Republic of Ireland they do have a different sort of training scheme. So we're not sure about that. You might need to inquire there. Okay.
Yeah, another similar question asking about the Irish system. What is the selection process for basic specialist trainees in Republic of Ireland? I'm not sure if we could answer that one.
Yeah, there's loads of stuff on their website. Yeah, if you have a look there, it's probably best.
If you contact them, I'm sure they'd be really pleased to answer those questions.
Perfect.
Thank you.
Okay, the next one says, thank you for this session. What is the scope for interventional procedures in clinical oncology?
Okay, thank you. I can certainly take that one. So I specialise in gynae cancers, and we do a lot of brachytherapy in prostate cancer as well. So obviously, if you're not that keen on interventional procedures, you can still become an oncologist. But if you're a clinical oncologist, then you can get very involved in, particularly in the brachytherapy. So we have a weekly theatre session where we give brachytherapy treatments. There we are. Thank you.
Perfect. So the next one is for medical oncology. Are part-time M or ES or MSCs generally encouraged / funded?
So Tinder, are you able to take that one?
Simon, are you going to take that? Shall I take it?
Yes, please,
in terms of the in terms of opportunities for out of program training, really it's variable across the board, but it's looking at specifically what you want to do and what you may wish to pursue. I mean, there are universities that provide MSc courses in oncology and MRes courses. It won't be fully funded from the study leave budget, so that's something to discuss with the individual TPD, I guess, and look at the opportunities locally for that.
Lovely, thank you. Keela?
Perfect. So how much exposure to brachytherapy is there for somebody who would be keen to carry on procedure-based things during training?
Okay, so I can answer that one again. So during your training, in clinical oncology, you would rotate around the tumour sites. Obviously, as consultants, we often specialise in 1 or 2 or 3 tumour sites, but you would rotate round, and during your gynae and your urology rotations, you would get exposure to brachytherapy. And then when you become a consultant, obviously you would have the opportunity then to site specialise in that area. Thank you. Keela?
Perfect. So the next one is, I did research during my MSc but didn't publish. Can I score a point for research for this and still score for MSc?
Ruth again?
Sorry, say that again. Basically, so if you've not published, then you wouldn't get a score for the publication bit, but you would certainly get your score for your postgraduate qualification. Yeah, I think that was the question, wasn't it?
Yeah, perfect.
Thank you.
Okay, great. So these are the last few now. So should the presentation be related to oncology only?
No, you score more points, but again, we really understand that not everyone will have had that opportunity, so if you've done a great piece of work in your dermatology or your cardiology rotation, we want to know that as well, because they're transferable skills. It shows a level of commitment from your part as well as those skills, so you do score. So again, if you go on the website, look at the self-assessment scoring, it gives you really detailed breakdown of what you'd score maximum points for and what you'd score at other level of points for. Because I think there was another question that I kind of answered about, I've got several publications, but I'm not first author. You still get points for that. Again, we know that at the level of IMT2, not everyone will have had the opportunity to be first author on a piece of work, and that's fine, but you can definitely still get credit.
Thank you. Keela, how are we doing?
So we have a few more still trickling in, but we have reached the end of when we did say we would cut them off. So I'm not sure how you want to proceed, Louise.
Okay. Any sort of brand new ones? Because I think we've gone over by 9 minutes, but is there anything that's brand new, or is it all?
Yeah, we have. Does more than one postgraduate degree count as more points?
I think the answer is
no.
No,
You don't need to score for the highest level postgraduate kind of thing. You can't score multiple.
Okay, perfect. And are there mentorship opportunities for international medical students with an interest in clinical oncology?
Yeah, so we do have a RAD-REACH program within the RCR that helps to support people who are interested. So I think if you go on the website and look on the resources there, that will help to tell you what's available.
Perfect. And then there's 2 more in there, so I think we'll just go ahead with them. So the second last one is, thank you for the session. If I have a poster presented at BTOG and the article is referenced within an article, is that still counted as a publication?
I think if it's referenced, but it's not the actual publication, I think that would count as a poster. Yeah.
Perfect, thanks. And then this one has just a few elements to it. So I'll read the first 2 together. I think they match. When is the best time or earliest time to start FORCS clinical oncology exams? Is it possible at IMT level, assuming MRCP is completed? And then does the FORCS portfolio begin at ST3?
So it's FRCR, so it's the Fellowship of the Royal College of Radiologists. We would generally advise you to do those during the training programme, but you can do the exam independently of a training programme if needed. But we certainly, you don't need that. You won't score any points for having FRCR during the application process. So it's certainly not necessary. And then the portfolio does begin at ST3. Yeah.
Okay, and the final question then is, if I decide to take time off training for a PhD, can I opt for on-calls to shorten training length and also prevent de-skilling?
So I guess a couple of different issues there. So you will need to decide before you go out of program how much of your time out of program you want to count towards your training. So that will be discussed beforehand. So that's not necessarily about doing on calls. It depends what you're doing with your time out of program, and if you are getting relevant clinical experience or not. And then the doing on calls is a slightly kind of separate thing that you would have to discuss with your training program director, really, and your kind of service managers. So certainly I have some resident doctors that want to keep doing on calls, partly to keep their skills up, partly financially. But that needs to be looked at, because obviously you've got to think about pay, potentially getting paid from different sources and things. So that's something that would just need sorting out kind of locally, really. But often people find there's lots of ways to make sure that they keep up their clinical skills. And also when you're coming back into program, I think pretty much everywhere now has a return to work program, because we acknowledge it can be difficult if you've been out of program for research, for maternity leave, for whatever. So most places will have a very structured support RT, so a return to work programme to help with that. So don't worry too much about that.
Thank you very much. So I think we're going to wrap things up now. So thank you so much to David, Ruth and Martin, Simon, Satinder and Ben for the great presentations. We hope we've whetted your appetite as to what a fantastic specialty and career oncology is. Thank you so much to Jackie and Keela from the college for helping to administrate the webinar. Please do have a look at the RCR website and also the RCP website for medical oncology. My email address is at the bottom. I'd be happy for people to contact me with any questions. That's the underscore between my two names at the RCR. And do go to the RCR Choose Oncology webpage to stay in the loop. So it's been great having you all attend the webinar. Thank you very much for joining us, and we really look forward to having you on board within clinical oncology or medical oncology. Look out for the medical oncology webinar, and we hope to see you all soon. So thank you very much.